Hello, everyone. This is Shahad Hardan, and I'm going to present to you our study titled Machine Learning Multimodality Fusion for Antimicrobial Resistance Prediction using Electronic Health Records. This work is a collaboration between myself, Dr. Jihad, and Dr. Mohammed Yaqub from Mohammed bin Zayed University of Artificial Intelligence. So first, we'll introduce the problem. Why do we really need to predict antimicrobial resistance using machine learning? What data are we using? How we're pre-processing it? How we're exploring it? And what multimodality approach we use? Then we'll discuss the results and the conclusions from these results. So one problem that the healthcare system is facing right now is the rise of antimicrobial resistance. But why is that happening? Because of the inadequate usage of antibiotics that lower their effectiveness. So this inadequate usage is either coming from physicians that are not properly prescribing antibiotics or from patients that use antibiotics without prescription. So as a result, what happens is that the body of the patient stops responding to this antibiotic. So it leads to some clinical drawbacks. And for the hospitals themselves, they are paying so much to try to control this problem. So it also results in economic drawbacks. According to the WHO, antimicrobial resistance, or AMR, is going to be the greatest threat in the healthcare system by 2050 if we do not control it. So if the control isn't happening, then there will be around 10 million deaths by 2050. So what's our goal? What do we need to do? And how can machine learning help in controlling this problem? So our goal is trying to use electronic health records to help these clinicians to predict the antimicrobial resistance early on for better antibiotic prescription procedure. So we're using machine learning and we're using EHR data. But why do we need to do that? Why do we need to follow the approach that we're following? One, because there are very few studies that are focusing on antimicrobial resistance. And even these studies are only addressing it using classical machine learning. So we want to use deep learning models because they're better at capturing the patterns in the data. Most studies are also using genomic data versus EHR data. And genomic data is it's good, but it doesn't capture the patient history, while EHR data does capture the patient history and is very rich. So we want to leverage it. We want to leverage the modalities in the EHR data. And we want to also deal with these modalities using the multimodality fusion techniques using deep learning. So we're trying to cover these research gaps that are not yet covered in the field right now. And we're trying to set a benchmark to explore different perspectives into using machine learning and leveraging EHR data for the prediction of antimicrobial resistance. So I've been saying EHR data. What exactly is EHR data? So electronic health records is a digital format of patient information. It's very highly dimensional and sparse. But why is that? Because there are so many features that a physician can record about the patient, right? And because my case would be different than your case or any other patient. So in this, and from this regards, we will have some sparsity. There might be some feature that is recorded for me, but is not recorded for you. EHR data is also multimodal. It contains structured and unstructured data. It contains different types such as categorical, numerical, and so on. So for our case, we're using the MIMIC database. The MIMIC database is publicly available. It's an EHR database that is collected for around 11 years for 350,000 patients. It has so many tables, but from these tables, we use these 14 tables. And we're focusing a lot on microbiology events because this is where we can derive our outcome, which is the sensitivity or resistance against an antibiotic that is prescribed to the patient. We are also using the other tables that are presented, and these tables, as you can notice, some of them are time invariant, some are time dependent. What does that mean? For example, if you record your demographic data, which is like your gender, it's time invariant, it doesn't change over time. While if you want to do the lab tests, you might do a lab test today and then do another one the next month. So this is dependent on the time. So we have now the MIMIC database. How can we pre-process it to be able to use it in a multimodality approach? So for our study, we used the FIDDLE pipeline Fiddle goes through 3 phases. The first phase is pre-filtering. Pre-filtering eliminates all the less presented features in the EHR data. We are trying to reduce the dimensionality and reduce the sparsity in the data. Next, after that, we transform our data set into 2 different matrices. One is time invariant and the other one is time dependent. And you can see for time dependent, we have another dimension, which is L, that captures the change in time. Then after that, we go to post-filtering. Post-filtering again removes the less informative features. So we're trying to make our matrices as clean as possible. So we have 2 outputs. One is the time invariant matrix and the other is time dependent matrix. So now that the data is pre-processed, as we said before, we are trying to set a benchmark to exploring AMR problem using machine learning. So we had the question of where do we start? So we explored the most common antibiotics in the mimic data set. We noticed that gentamicin had the highest occurrence. So then if we want to move forward with gentamicin, we want to analyze when a patient goes to the ICU department, when exactly do they get prescribed with gentamicin? So we notice this plot. This plot has the hours of the ICU, and we can see that most patients have gentamicin a bit before 15 hours. So we're trying to focus on this time period, and later we did more analysis according to the prediction time. So this analysis is dependent on starting with the prediction time of half an hour after the admission to the ICU until 12 hours. And we excluded the deaths, we excluded the discharges before this prediction time. And we lastly chose the prediction times of 3 and 4 because they kind of capture a balance between the prediction time and the size of the data set. So the higher we go in prediction time, the lower our size is. So we want to have some kind of a balance. This is why we went forward with prediction time of 3 and 4. There's another filtering criterion that we also explored. We're not going to talk a lot about it in the presentation, but you can read more about it in our study, which is the pathogen-based. So as mentioned before, that we considered gentamicin as the antibiotic that we want to test the resistance against, but we're also wondering what can happen with the model performance if we consider the pathogen as the indicator, meaning that if we only take the patients who are infected with a specific pathogen, even if they take different antibiotics. And we specifically focus on the Pseudomonas aeruginosa. But as I said, we're not going to focus a lot about it in this presentation. So to wrap what I set up, what happens in a clinical setting? Why are we trying to use such an approach? First, in a clinical setting, a patient gets admitted to the ICU, and then they have their ICU data collection in the EHR database. But the patient also might be in the hospital, or they might also have a health record before this ICU stay, right? So we can take this data from the ICU, and we can also combine it with the available patient history even before the ICU. Then the healthcare provider wants to know the outcome of the resistance of this patient. So what they do is that they call the model, which is our model, and we extract the data up to the prediction time. We pre-process it using Fiddle, as we mentioned before, and then we go to the machine learning model. And finally, this machine learning model tells us whether the patient will be resistant or sensitive against a specific antibiotic that we're trying to study. So we're not really discussing up until now about the machine learning model, so let's start doing that. So we're focusing on a multimodality approach. And for this multimodality approach, we take the Fiddle pre-processing outcomes, and we have 3 different modalities: time series, time invariant, and clinical notes. We use 3 different types of encoders for them, an encoder for each of the modalities. And then once we have the data encoded, we use 4 fusion mechanisms to test the difference between these fusion mechanisms. For us, our fusion mechanism that really outperformed in the results, as you'll see later, is the multimodality Infomax, right here, that depends on 3 losses, and we'll talk more about them later. So let's start by encoding the modalities. First, for the time invariant data, it's very simple. We take a linear layer, and then we follow it by a ReLU activation function, and then we will have the encoded representation of the time invariant data. For the time series data, We use different encoders, could be an LSTM, could be a CNN, could be a transformer, and you could also choose other layers, other models that you want to encode the time series data with. And then we also followed by a linear layer and a ReLU activation function. So we have now an encoded representation of the time series data. And finally, we also encode the text data. For our case, we're using clinical BERT. There are plenty of options according to the BERT architecture available, but clinical BERT resonated more with the type of data that we are trying to analyze, which is the clinical notes from the physicians that describe the case of these patients, and they have plenty of information that we can use to analyze. We move now to the fusion mechanisms. We have our encoded representations for the three modalities. We want to fuse them, want to see how can we leverage, as we said before, the EHR data and its richness to predict the outcome of the resistance or susceptibility against this antibiotic by a patient. So we explore 4 different fusion mechanisms. First is the MAG-BERT. Briefly, what the MAG-BERT does is that it takes a main modality. Let's say this main modality is text, maybe. It calculates a multimodal representation with respect to this main modality. And then it uses a multimodal adaptation gate to calculate this representation. Then we have attention fusion. Attention fusion has 3 different transformers for each of the 3 modalities, and then it calculates a cross attention between these transformers. Third, we have the tensor fusion. The tensor fusion has representations for each of the modalities, and then it calculates an outer product of these representations. Fourth is the multimodal InfoMax. It aims to maximize the mutual information. This is our keyword, the mutual information between inter and intramodality fusion data. So since we preferred using a multimodal InfoMax, as we will see later, we'll talk a little bit more about it. So multimodal InfoMax, it considers 4 different steps. First is maximizing the mutual information at the input level. So what this means is that we have the mutual information between modality, which is text versus time series, text versus time invariant, and then we try to understand how can we maximize this mutual information between them. Then maximizing the mutual information at the fusion level. So we have the fused vector that represents all 3 modalities, and we want to maximize the mutual information between this fused vector and each of the 3 modalities. And the third part is predicting the outcome. So we have 3 different losses, one from maximizing at the input level, one from maximizing mutual information at the fusion level, and the third is the prediction loss. We combine all these 3 losses and we optimally try to reduce the loss for a better performance of the model. So now that we discussed all our fusion mechanisms, let's move to the results. So for the results, we'll focus on 2 different cohorts. First one is the gentamicin antibiotic prediction time at 4 and the time granularity of 1. So every hour, basically. And then we take the number of samples extracted after merging all 3 modalities, and we consider the imbalance ratio. Our imbalance ratio is really high in this case, which is 12. So for example, we have 12 sensitive cases against every resistant case. And this is a bit challenging. And why does it cause a challenge? Because we really want to focus on the resistance cases. This is where the risk lies, right? So we want the model to be able to handle this imbalance and understand when does a patient profile lead to this resistant case. So for that, we tested first using only one modality. So either using the time invariant only, time series only, or the text only. And then we compared these results with the fusion techniques. For the comparison, we were using 2 different metrics, the AUPR and the AUROC. For our case, AUPR is really important because of the imbalance in our data. We use different losses, binary cross entropy and weighted binary cross entropy and cross entropy later. We will notice in this case, for example, the one in bold, that the weighted cross entropy had a better result because it's weighted, so it does take into account the imbalance in data. But this is using MAG-BERT, right? And we want to try different fusion mechanisms. So the one that outperformed all the results is the model that had BERT for encoding the text and the text as the main modality, LSTM for encoding time series, and then multi-model Infomax for fusing these two modalities. It gives us an AURC of 0.75 and AUPR of 0.18. So now we're done with the cohort of the prediction time 4 hours. Let's move to 3 hours. For the cohort of 3 hours, we have less data. And this less data is taken after merging all of the 3 modalities, meaning that we consider the patients that have all three types of data. Then we have less imbalance ratio, like a lower one in comparison to the cohort of prediction time 4. And we ran the same type of experiments, so taking only one modality and different fusion techniques. And we also find the same result, which is that BERT LSTM using the multi-model Infomax led to the best result for this cohort, considering prediction time of 3. We started to explore the prediction time of 10. And for that, we had a higher imbalance ratio of 14. And this higher imbalance was also challenging for us because the results of the model were not very valuable for deployment, even if you want to think later of deploying it in a clinical setting. Throughout all the results that we have been discussing, we noticed that there's a trade-off between AURC and AUPR, and this trade-off differs between models, but as we discussed, that AUPR is very valuable for us because we have this imbalance and because we really care about the resistance cases. The effect of imbalance was huge in our case, and we should think of more ways to handle this imbalance. Clinical notes were used as the main modality in our case, and we saw that when we merge these modalities, we can get a better performance of the models using the fusion techniques that we were trying. So out of these fusion techniques, multi-model Infomax had the best result, and it also had a significant change in the results of multi-model Infomax if you want to compare it with the previous fusion techniques that were used in the literature. So in conclusion, we saw how throughout our approach, we were trying to set a new milestone for predicting antimicrobial resistance using the fusion mechanisms and using electronic health records. We use FIDL to pre-process the data, and this is a really important step in our approach because the way you handle the data really plays a huge difference in the performance of the models. Out of the fusion techniques, we want to further use multi-model Infomax because of the significant change it made. And for future work, we're hoping to handle the imbalance in a better way. We are hopeful that this will actually improve the results way more. We want to extend to outpatient settings because right now we are only predicting for patients who are admitted to the ICU. But what if a patient only is coming to the physician for one time and maybe future visits, but this patient doesn't really stay in the ICU for 10 hours or 4 hours, or similar to the analysis that we have done. We also want to consider irregular time series models because previously we only had regular time series models, but the data in the real life scenario is irregular. So we want to explore that as well. If you're interested in our study, you can read more about our study in this link that is provided here to you. And our study was published in Nature Scientific Reports, so you will be led to this link. Our code is available and the data is luckily also publicly available, which can offer you a chance to reproduce our results and explore the data more. Thank you, and you can check these references if you're interested in more information.